Good morning, everyone. We welcome you to our IC on small incision lenticle extraction. So we'll cover the talks in series, and I'll be starting with the initial talk focusing on decision making and patient selection. So I'll be covering understanding the machine and laser settings and preoperative case selection and patient counseling. There are no relevant financial disclosure. So, small incision lenticle extraction has gained popularity since its introduction, owing to a lesser adverse effects on the ocular surface, less dry eyes, and greater biomechanical stability. However, it is definitely more challenging to perform than conventional lab-based procedures that we were used to earlier, with lenticle dissection and extraction being very challenging and an experience of at least 80 eyes required to perform SMILE consistently in less than 5 minutes. So, what's important is to understand the machine and laser settings and optimize patient selection to help achieve consistent good outcomes. So, there is a treatment pack in SMILE, which is a single use disposable contact lens with attached tubing. The patient interface is based on attenuation rather than applanation, as in LASIK. And there are three sizes: small, medium, and large. Generally, the Indian population is suited to a small size of patient interface with a 11.2 wide to wide diameter. The Visumax femtosecond laser system employs a 1043 nanometer femtosecond laser with a pulse duration of 220 to 580 femtosecond and a frequency of 500 kilohertz. So there are three modes of treatment: standard, fast, and expert. Standard is the default parameter set by the manufacturers. The fast mode may be altered only by the application specialist and consist of preset laser parameters that may be customized as per the region, and then you can use the fast mode in your cases. Expert mode allows surgeon control over the machine settings, and within a certain range the surgeon can modify the laser parameters. It is advisable to always consult the application specialist before trying to alter the laser and energy settings. So, what do we understand by the different parameters that are displayed on the screen while planning treatment? Spot spacing is the distance between two adjacent laser spots. It ranges from 2 to 4.5 micron, and you may modify it in the expert mode in steps of zero point 0.1 micron to a maximum of plus minus zero point 0.5 microns. Track spacing is the distance between two laser spots in adjacent tracks. It ranges again from 2 to 4.5 micron and is modifiable in steps of zero point 0.1 micron to a maximum of zero point 0.5. Scan direction is the direction of the spiral that the laser follows while making the cuts. It's spiral in for the posterior plane and spiral out from center to outwards for the anterior plane. Scan mode is preset as single, which refers that the entire lenticle is created in one go. Pulse energy is the size of the cavitation bubbles which are produced during laser cuts and range from the 100 to 260 nanojoules, and recommended is between 100 to 160. So one energy offset is equal to 5 nanojoules, and we keep the offset in between 20 to 32. The expert mode allows the surgeon to modify the energy offset by a total of 6 steps in either direction. So total of 30 nanojoules energy can be modified in either direction. So how does modifying these laser and energy settings work? If you decrease the spot and track distance, the spots and tracks are placed closer together, so there will be smoother cuts. However, more energy is delivered. Vice versa, if you increase the spot and track distance, they may have more adhesions and less smooth cuts. However, the total energy delivered also decreases. If you decrease the pulse energy, less energy leads to faster visual recovery and better quality of vision. However, more adhesions may be present. So it's a fine tuning basically of having the least amount of energy to give the smoothest cuts and minimal adhesions, which you gain with experience. So this is just a summary of the three different modes available: pulse energy, energy offset, track distance, and spot distance. So the track and spot distance for the lenticle and cap cuts, it's generally around 4 to 4.5 microns, and for the side cuts, it's kept around 2 microns. These are the cap parameters. The cap thickness ranges from 100 to 160. We usually keep around 120. Now people are experimenting with thinner caps as well. Cap diameter is conventionally 1 millimeter more than the lenticule diameter. Incision position can be placed anywhere. Conventionally, it's placed generally slightly superotemporal for the right-handed surgeon, around 110 degree. Incision width varies from 2 mm for experienced surgeons to 4 mm for beginners. Cap side cut angle is conventionally cut 90. And lenticule diameter ranges from 6 to 7 mm. Transition zone of 0.1 mm is preferred when you have a cylindrical error. It's 0 if you have a pure spherical error. And minimum lenticule thickness refers to the lenticule edge thickness, and it should be kept at least 15 microns. And if you have a very low myopia, you may keep it higher in initial cases. And lenticule side cut angle varies from 90 to 135 degree preferred. So coming to patient selection, so this is our review article on in clinical ophthalmology regarding patient selection and perspectives. So preoperative preparation is essential. So what comprehensive history, ocular examination, investigations, and patient counseling should be taken into account before going for surgery. So let's come to history. It's more or less similar to the flap-based procedure that we are used to. Smile is FDA approved for 22 years or more. Younger age group, refractive instability, of course, you have to rule out any refractive procedure. And contact sports with any risk of traumatic flap dislocation may be better suited for smile. And for occupational purposes, you have to take into account the restriction placed on the minimum UDBA or CDBA by the specific occupation and type of refractive surgery that they are allowed to undergo. Systemic history, the contraindications are similar to other corneal ablative procedures: pregnancy, lactation, uncontrolled diabetes, collagen vascular diseases, et al. And any medications that may lead to ocular surface issues, abnormal wound healing, dry eyes, again should be looked into before undergoing for refractive surgery. Refractive stability with the manifest refraction spherical equivalent of less than equal to 0.5 change over the 1 year has to be documented. Past or family history of corneal ectasia should be ruled out. Any contact lens usage should be looked into. Examination, again, smile at present is FDA approved for a myopia of less than -10 diopter, a manifest refractive spherical equivalent of equal to -10 diopter, and astigmatism up to 3 diopter. CE approval is up to a manifest refraction spherical equivalent of 11.5 diopters. Investigations, again, the topography, pachymetry, contrast sensitivity, a barometry has to be done to rule out any contraindications similar to any corneal-based refractive surgery. Percentage tissue altered is a relatively new index, and it's calculated in smile as lenticule thickness plus cap thickness by CCT, and the cutoff is 40%.
Manpreet, just hold on.
Yes, sir.
Can admin send a link to Dr. Rupal Shah? She's not got a link.
Okay. I've been able to join, sir. Thank you.
Thank you, Rupal. Yeah.
So coming to patient counseling, you have to address the patient expectations, because unrealistic expectations of a perfect vision or improvement beyond CDVA may not be fulfilled, and unhappy patient and unhappy surgeon may be encountered. You have to explain the surgical procedure, the various surgical options, their pros and cons in detail, the possibility of complications, potential implications, and answer all doubts and query preoperatively. You have to importantly explain patient role during surgery. The patient should be able to lie down flat during the whole duration, follow the surgeon instructions, fixate on the light, and avoid moving or squeezing his lids during surgery. This is especially important because smile is a low suction procedure, and the incidence of suction loss does decrease if you counsel the patient yourself and the patient knows they have to look at the green light, and then it will disappear during laser application and everything. So consent should ideally have been read and understood by the patient before signing, ideally a day before surgery, and the patient should not be sedated or pupils dilated while doing so. Coming to decision making. So the ocular surface stability, corneal nerve regeneration, and a lesser incidence of dry eyes is observed in smile. So it's a better choice for patients who have mild ocular surface disorders preoperatively but are still motivated to undergo a refractive procedure owing to the less subbasal corneal nerve damage. As you can see here, this is SMILE preoperatively, post of 1 month and post of 6 months with nearly a similar nerve pattern as seen pre-op. And in LASIK, you can see the nerves have not even started regenerating significantly. So flap-based procedures have a vertical transection of the collagen lamellae in the strong anterior and peripheral stroma and are said to be associated with greater biomechanical weakening. In addition, they have all the flap-related complications, dislocation, buttonhole, irregular flap. SMILE leads to a transection of the collagen lamellae only at the site of the cap side cut and preserves majority of strong anterior and peripheral collagen lamellae. So it is said to have superior biomechanical stability, though the results are still inconclusive because you have contradictory studies. Still, SMILE is said to be more biomechanically stable. The, then you have to look at the type and magnitude of refractive error. For now, SMILE is still 10 diopter of myopia and up to 3 diopter of cylinder. And it's not FDA approved for hyperopia at present. Those studies are still underway and it's made good progress and may soon be approved. For a lower refractive error and thin lenticule, typical dissection in the early learning curve may be experienced. And for a higher refractive error, SMILE may be beneficial as it has better biomechanical stability. Coming to anatomical features and patient factors, deep-set eyes, small palpebral fissures, anxious patient unable to follow instructions is more predisposed to develop suction loss as SMILE is a lower pressure system and may be more suited for flap-based procedure. Pupil size. So, as you can see, SMILE is less sensitive to a larger pupil size and has less higher order aberrations. This is a case of SMILE with higher order aberrations of 0.29, and this is a case of LASIK with 0.48 microns. So, patients with larger pupils tend to have more pronounced symptoms due to increased spherical aberration and may be better suited for SMILE. Enhancement and retreatment. There is no established protocol for performing a repeat SMILE at present, and you have to go with flap-based or surface ablation procedures or the circle pattern. So just to sum up, SMILE may be better suited for patients with pre-existing ocular surface disorders, high refractive errors, and contact sports. For hyperopia, higher astigmatism, post-refractive surgery, enhancement, LASIK or PRK may be better. So just a summary of the case selection for beginners. Avoid difficult cases like low myopia with resultant thin lenticules, difficult orbital anatomy, uncooperative, extremely anxious patient, high astigmatism where cyclotorsion compensation is desirable. Thank you. This is our book by Professor Tityal and me on SMILE surgical techniques and challenges, and will be very useful for beginners to go through. Thank you for your kind attention.
Yeah, thank you, Manpreet. You have very clearly explained the entire selection of patients. The machine dynamics, its characteristics, the parameters, beautifully explained. I think it makes the very, very clear understanding for people who are going to be a SMILE surgeon, because I understand future, every refractive surgeon would have this device or these type of devices with them, because this is going to be a future of laser refractive surgery for most younger people. Beautifully done. I think now we can shift to the next speaker.
Next, we have Dr. Rupal, who will be taking us through the technique of small incision lenticule extraction.
Thank you. Thank you, Dr. Manpreet. It was a very nice base on which we can go ahead. You spoke really well. Is my screen visible?
Yes, ma'am.
And I'm also audible, right?
Yes, ma'am.
So I come from good morning, everyone. And I come from the land in which Mahatma Gandhi was born. So I would like to start the day with a quote from Mahatma Gandhi, that live as if you were to die tomorrow, but learn as if you were to live forever. And that's the attempt, I think, that you are creating here, Dr. Manpreet, that whatever happens, whatever are the circumstances, learning cannot go away. So I'm just going to be describing some tips and tricks that I follow for a perfect smile. The standard technique, as we all know, has become quite good. And you could actually do a good smile procedure if you have such nice energy parameters. What normally I do is make sure that the patient is comfortable, has understood the procedure, that I have talked to the patient, I have seen some aspects, especially the refraction, so that I know exactly what I'm dealing with, how anxious or how easygoing the person is going to be. And that also helps you to go through the procedure with the patient inside while it's going on much easily. And the standard technique nowadays is to create one incision between 2 to 4 millimeters and to be able to extract this after completely separating the lenticule right at the edge of the incision so that you can easily remove it. So that's what the standard, you can see this is a very thin lenticule. Sometimes it's difficult to grasp. And I wash on the surface so that you can have a good ironing, which helps in the next day recovery. So what is next important is to have a good centration, because a good centration is very important in this particular procedure where your lenticule is also refractive. It's different than creating a flap where if the flap is slightly decentered here or there, it would not really have any impact on the final outcome. So centration has to be learned the best. For centration, what I normally do is not start or not put the speculum in till the patient is quite in focus. And he's only about 5 centimeter or so away from the cone. Then I put the speculum in and I tell the patient to look at the green blinking light. If the green blinking light is close to them and if they can see it, then the chances of it moving and their eyes moving and creating differential hydration on the surface and everything goes down. Since the eye was closed and you open it, the tear film is also present there enough and you would not get dry eyes, dry spots or black spots. When the patient is looking straight ahead at the green light, you would also know where your visual axis is. So in myopia, there may not be a big difference, but in hyperopia or when you are doing those cases where sometimes there is a big angle kappa, you would want to also focus and do on the visual axis, and it's possible to do if you pay careful attention to where that green light is and where the patient is looking. Once the patient is looking at the green light, you get the cone up and I don't do a complete applanation immediately. So the white ring and the green light should be in the center of the pupil or where the light reflex is. And once you have 3/4 of the applanation like this, then you can have the suction on. And I always check with infrared immediately so that in case I am not having a good centration, I can immediately release and refix it. If you wait too long, it would go in the same footprints and then you would have the same recentrations occurring again and again. So it's better that you check immediately, and if you have any doubt, just leave it immediately before you actually go ahead. Then while the treatment is going on, it's very important to prevent the suction loss. Suction loss would happen, as you pointed out, because the suction is not, it's a soft suction. It is not really holding your eye too tight. And that's why the patient can also see the light till almost the end of the procedure. But it has a flip side also, that if the patient is too anxious and starts to blink or starts to move the eye or the head, then you can have a suction loss. So a good idea to prevent a suction loss is to, of course, have good anesthesia so that the patient is comfortable. More important is to have vocal anesthesia throughout the procedure. So you keep talking to the patient, divert them, tell them about your experiences, ask them about theirs, and tell them not to speak, but at least keep listening, keep telling them that there is going to, you are almost there. that there is only 15 seconds left, and then you start counting backwards or you count with them. Do whatever you can. Tell them to think of a happy moment in their life. By the time they actually can think of the happiest moment of their life, the 25 seconds that you have to pass would be over, because if you ask them about the sad moments of their life, they'll be able to counter a lot of them within a few seconds. But happiest moment, you have to really think. And that is the time when the procedure gets over. So it's very important to keep talking to the patient during the procedure. Today, it's the whole thing has become much easier because they are faster lasers, and the suction is also pretty good. Initial days, we had to adjust that, and initially the laser was also taking a little longer. But nowadays, it's very, very easy to have a prevention of suction loss. In case suction loss occurs, it's not really a big problem, as the next speakers would point out to you. Once there is a good treatment done, then we come to the initial separation at the incision site. It's important that you take the patient on the, we are lucky to have a operating or a surgical microscope attached to this laser, and therefore you get enough depth of focus as well as the working distance, which generally lacks when you are doing a excimer laser procedure. And therefore, it's very easy to find these planes. It's important that you're doing it as quickly as possible when you have the bubbles also there to guide you. Then it's very easy to find these. Once the bubbles go away, it becomes a little less easy because there is no guide. It looks like a normal cornea almost. So try and do it as quickly as possible. Get the patient in focus. There's also a slit lamp attachment, so you can make use of that on the surgical microscope if you find that you are not able to find the planes well. So what I do is I open the entire incision, then I enter on the left side of the incision in the upper plane and the right side of the incision in the lower plane. And you can see two distinct planes occurring here. And you would find that when you are in one plane, you cannot go to the other without much resistance. And therefore, which is known as the stop sign described by Dr. Ramamurthy. So that really helps. Once you can quickly find these initial planes, the whole procedure becomes absolutely smooth. Because then you have to just free the lenticule. For freeing the lenticule, you first enter the left side where you have created the upper plane and then the lower plane on the right side. And usually you'll find that you are not in the wrong plane at all. What you have to make sure is as soon as you start separating, make sure that you are not finding a lot of resistance or a line developing. As you can see here, I'm in the bottom and you can see a line of separation developing at the lenticule edge. If you find that that line is developing, you stop immediately and don't go ahead and free the entire area, because it would mean that you are in the wrong plane. Also, it's important that you are using your instrument as a fulcrum at the center and not taking it side by side horizontally. So you should have the center in the center of the incision and the instrument should be moving side by side. I'll just play it once more. So I'm entering in the center and then turning my instrument and not taking it only side by side. And it's so like a windshield wiper. And you would find that the separation is very smooth, and also you would be able to find your planes easily. For separating the lenticule and not allowing it to fold on itself, it's important to leave behind some tags at the edge, which you can then remove. See, I'm going and removing the last tags at the end so that it doesn't fold on itself when you're going to the other side. And finally, you grasp the lenticule at the edge and remove it, followed by a thorough wash and ironing of the cap. Ironing of the cap is very important because that leads to a good visual recovery. I generally don't go in and wash. Only if I find that I have handled too much or entered too much, I go in and wash. And at the end, I just make sure that the incision is getting dabbed like this, so that there is no open area from where the fluid can egress in, or if the epithelial cells can grow in. So it's a very simple procedure, but meticulous meticulous attention to details is very important. And there are now different lenticule extraction techniques that one can follow. This was the standard one. Lenticular scissions, you are not separating the planes, but just making only the initial incision and then grasping the lenticule and removing it without, I think we are in short of time, so I'll just not go. And you could also do lenticule peeling if you find that the separation is not happening very easily. So you can grasp the lenticule and remove it like a capsulorhexis. So I'm trying here to separate, but I could not. So I'm just holding it. It's an unedited video, I'm so sorry. You can hold and peel it out like this. Here you should leave and grasp again and again, and you can actually remove it like this. And you could use a rescue instrument where if it is stuck to the top, you could go to the end of the instrument, and this is a special instrument which can just peel it out from the undersurface of the cap like this. So thank you very much, and I'm sorry I extended my time a little bit.
Thank you,
Thanks
ma'am.
for the opportunity, Manpreet.
No, ma'am, we are honored to have you with us, and thank you. It was a wonderful talk, and you are saying easy and simple all throughout, but I know for a fact that it's not easy, it's not simple. It does take a certain amount of experience, and it was beautiful.
I agree with
ma'am.
you. There is a little learning curve, but if you pay attention to details,
Yes,
and then I think it works very well.
yes,
It's also a very satisfactory procedure.
yes, ma'am. Thank you so much. Next, we'll have Professor Tityal, who will cover the intraoperative complications, suction loss, and difficult lenticule extraction.
Yeah, thank you, Manpreet. Indeed, we had a master class from Rupal, and we know that she's been a pioneer in this field, and we are very proud that she had taken us to this stage of refractive surgery. In fact, we call her, grandmother of refractive surgery in India. Wonderfully, explained everything, and things have become very, very simple for us also. For people who are going to listen to Smile as this masterclass which is going through should learn many things from experienced people. I would not say a complication. I would say these are difficult situations in any surgery, and true for a smile procedure also. No financial disclosure from my side. As Dr. Manpreet talked about, and Rupal also, we know that there's a definite learning curve initially when you get initiated into this surgery, and satisfying surgery, as Dr. Rupal Sir told us, because this looks like actual surgery in the cornea rather than LASIK, which is mostly governed by the machine parameters and machines doing everything. So we know that suction loss can be sometimes very challenging in a patient undergoing smile procedure. The incidence is very low. In the beginning, it may be around 2% or so. That is what I felt in the initial 100 cases. But subsequently, it is hardly there. That means you have understood very correctly the entire procedure and you applied your technique to the patient, and this little difficult situation can be avoided easily. As we talked about, it is a very soft docking, and it's not like in a patient with a LASIK or a femtosecond LASIK where you have a huge amount of section being there. It just accurvates the cornea, and the pressure buildup is so less, and patient can see the green light despite having a suction, the vision is preserved, and that's why you have a good fixation in these cases. What would be the various predisposing factor which can enhance the chances of suction loss happening during the procedure? As we said that it is a low suction system. So longer suction time, sometimes people inexperienced in the beginning can have much longer to take the patient into actual procedure. A patient may be very, very anxious because these are young patients, they have never been to any surgical room. In fact, this may be the first instances where they lie supine underneath the some system, and it's really terrifying. I've seen myself lying under this system can be terrifying, and it's like a sort of people I've seen they get crazy sometimes. The young patient can be very anxious. Tight speculum drape is another thing which we have to take care of, especially eyelashes coming in there. Conjunctiva getting boggy, as Dr. Rupal nicely described. If you do a multiple suctions, you have a very boggy conjunctiva sometimes. Deep set eyes, small aperture, and most importantly, surgeons' own anxiousness because of inexperience can be a factor here. Therefore, pre-op counseling is very important for all surgery. This is true for a smile also. You should talk to the patient, make patient comfortable. And it's not pre-op also, it is during the surgery also, continuous counseling is important. Speak to the patient, explain. And as far as I'm concerned, I tell them towards the end that this procedure is going to take hardly 28 seconds. And that also eases the patient because the procedure is not that long. And 28 seconds can go very fast. And it is very important to explain that green light be off after some time because otherwise they keep searching for green light. That these two parts are very important for these patients. What are the management algorithm we have to understand? Not much also because everything is guided by the system. First thing we have to identify the underlying cause and what stage the suction loss has occurred. So if it is within the first 10 seconds of posterior plane, that is a lenticular cut, you can immediately redock and restart the procedure. So that's the simplest for that. So if you have difficult situation visible, like you have a lot of conjunctiva getting boggy there, or there's a fluid collection happening towards the periphery of a suction contact lens, and that is increasing or patients moving, you should not proceed at that moment. Stop at that time, make the patient comfortable, and you can restart. The difficulty arises when you have a posterior lenticular cut more than 10%. Most of the time, we'll have to stop procedure and think of an alternative procedure or wait for a second surgery to be done in these patients. In other aspects, that is a lenticular side cut or a cap side cut, well, these are basically anterior dissection or laser procedure happening. You can redock and proceed as per the machine's guidance. So it is only the posterior cut which is important, and that you have to be very, very observant to see what stage you had the posterior cut. Let me just run one video here. Various factors may contribute to an increased incidence of suction loss related to the machine, surgeon's inexperience, anxious uncooperative patient, tight speculum, or difficult orbital anatomy. In this case, suction loss occurred at the beginning of the procedure due to excessive eye movement of an anxious patient. Preoperative counseling is essential to calm an anxious patient and explain what is expected from the patient during laser application. The patient should be explained that the green fixation light may not be visible during femtosecond laser delivery, and the patient should not become anxious and move the eye. The patient was counseled, redocked, and retreated uneventfully in the same sitting. The soft docking is based on the principle of accurvation, which minimizes the intraocular pressure rise as well as the tissue distortion during femtosecond laser application. It also allows the patient to maintain fixation throughout the surgical procedure. The low suction system is associated with longer suction times, which predisposes to the intraoperative suction loss. In this case, excessive eye I'm sorry, there's something went wrong. Incidence of suction loss, experience, anxious uncooperative anatomy.
due to excessive eye movement of essential to calm an anxious patient and explain what is expected from the patient during laser application. The patient should be explained that the green fixation light may not be visible during femtosecond laser delivery and the patient should not become anxious and move the eye. The patient was counseled, redocked and retreated uneventfully in the same sitting. The soft docking is based on the principle of accurvation, which minimizes the intraocular pressure rise as well as the tissue distortion during femtosecond laser application. It also allows the patient to maintain fixation throughout the surgical procedure. The low suction system is associated with longer suction times, which predisposes to the intraoperative suction loss. In this case, excessive eye movement by the patient led to suction loss after 2.81 mm of lenticle cut had been completed. The management depends upon the stage at which suction loss occurs. This case was planned for LASIK in the same sitting as suction loss occurred after completion of more than 10% of lenticule cut. The patient regained uncorrected distance visual acuity of 20/20 after the procedure.
I think the outcome after suction loss management can be equally good as you have patient without suction loss also. Only thing, the management has to be appropriate and decisions should be taken as per the stage of suction loss happening in these cases. And if you look into a management wise, there can be two options. One is look into a stage wise. If you have suction loss happening within the first 10% of posterior cut, you can redo it immediately in the same sitting wise. But if you have gone beyond that, there has been one article recently where they have continued despite the posterior lamellar cut has been more than 10% in the same sitting. And that may have some implications and which we normally don't follow as such. We normally abort the surgery at that stage and look for a second alternative to do a better procedure comfortably in these patients after refractive and corneal stability is there in these cases. The immediate redocking, sometimes you have a bubble which may be guide to your fixation and centration, but with the bubble also the energy settings can get altered and you may have undercorrection in these cases also. So you have to really look into that aspect, or some people might wait for 1 to 2 hours to get such these bubble to disappear. But that also makes things more difficult because your centration may be difficult as such in these cases also. Whatever we have done, it's few cases. If you have a patient where you have a suction loss happening after the posterior plane has been dissected by laser comfortably, we have redocked immediately and it has been quite successful also. The good visual outcome has been seen in all cases of suction loss without having to go through the difficult situation and explain patient your vision may not be regained. So in all SMILE procedure, there has been no vision threatening complications till date. As you say, this is the algorithm which we talk about. If you have suction loss, you can think of various ways of redefining the procedure for patient. Subsequently, we can plan for a transepithelial PRK once stability is there, or you can do a LASIK flap-based surgery in these cases, or we can try refractive lenticular extraction on like a pseudo SMILE procedure for these patients on the same sitting or a similar next sitting also. This is our video which is there American Academy site. People can see and watch the entire suction loss video in those cases. The second aspect which I would like to cover is, which Dr. Rupal also talked about, the dissection part, which we understand maybe the deterrent to many young people. They might find this is more difficult to really find the anterior and posterior plane in these cases. And the incidence of such inexperienced dissection can decrease with the experienced surgeon going through many similar steps being done. So always we try anterior dissection first, then do a posterior dissection, and Dr. Rupal very nicely showed. So two situations can occur. One, first, you have done a good anterior dissection, but you struggle to see the posterior dissection because of maybe thin lenticule, or you may have a bubble which not been correctly placed at that area, or some adhesions are there on the incision site, or you have done a directly went to the posterior dissection first, then you try to struggle to see another posterior plane. In that way, you can damage the stroma and cause more problems. So all complications related to a cap can start at this stage only. Once you have a difficult understanding of a plane, all complications start happening in these cases. Incidence will decrease with the time, with your experience. And if you have a difficult dissection, most importantly, we talked about delayed visual recovery for these patients. Suboptimal visual quality may be there, but we have seen that these patients also regain good quality of vision as time passes. That is the advantage of SMILE. As time passes, the visual quality and visual acuity keeps improving. This was my first case of not able to dissect the anterior or posterior plane correctly. And we looked into a case with anti-segment OCT to see exactly where we have dissected. So we could find that we have dissected posteriorly in this patient directly. And we had done a lot of damage to the stroma also, because trying to find another posterior plane in these cases. And with anti-segment OCT, we could appreciate the lenticule attached to the cap. So this is a cap lenticular adhesion. And we use the Sinskey hooks to delineate the cap, the lenticule from the cap in these cases. Once you make a little bit of crescentic flap here, you can subsequently enlarge the flap and do a dissection subsequently. This is what one video I like to show, how we manage these cases of a cap lenticular adhesion. This is the incision opening which you do. And this was a 3 millimeter incision. And you can see I'm dissecting, then trying to go in a dissection in a proper manner. So this is the time we're trying to go posteriorly. There's no space, and this is a space which is very, very clear. This is what had gone wrong. In the beginning only, we have gone posteriorly. With, you can see the little bit of space there. So that was a crescentic sign which we missed out. So we make a flap with the reverse tip of a sharper tip of a spatula, then go anteriorly. So making this flap is very, very important. If you just, I take you back there. You can see here, this is what we do it. Once you raise the flap, you have to go anterior to that flap, and this will give you anterior dissection very, very clearly. And you can do a same surgery as you routinely do for your cases. In fact, nowadays, if you get to a posterior plane in the beginning, you know that you are not going to damage the tissue. Complete the posterior dissection first, then make a flap and go anteriorly. So this is a posterior dissection first technique can also be used. This is the meniscus sign we had described. This is the anterior plane dissection first, and this is the posterior plane dissection. Both should be separate. And if you just nudge it, the tissue, you can make a crescent here. And this crescent, make sure that you have dissected both the planes, anterior and posterior. Now we'll go anterior dissection first. The crescent will be behind the line of demarcation will be underneath the spatula. That means you're anterior. Once you're posterior, this line of demarcation will be anterior to the spatula. And that makes that you are in a correct plane. So sometimes you can make a double crescent so that you can rexus the entire lenticule very, very effectively. People who do no dissection technique, I think the double crescent procedure is much better for separating the lenticule in a rexus manner. Other complication which can be cap tear or sidecar extension is normally associated with difficult dissection or a cap lenticular adhesion happening in these cases. This is what one case, I had a tear in the cap. So luckily it was a paracentral. And this was the only case I've seen in my entire last 5 years, SMILE time. And this is the extension of your side curve because of Dr. Rupal was saying, if your fulcrum is not in center, if you deviate from central fulcrum, then you can have this side cut extension also. This is the algorithm of a difficult lenticular dissection published in IGO. People can go through that and clearly explain how to manage the difficult lenticular extraction in these cases. So learning curve is there, but I think with the experience, you get to a stage where you don't think of any complication in your surgery, and same holds true for SMILE. And the outcome, despite having a difficult situation, has been reported to be good, and we have seen it is absolutely same as normal cases. thank you, Manpreet, for involving me in this particular beautiful IC or smile.
Thank you, sir. I think it was a wonderful presentation, and all the challenges that we faced were covered so well. And next, we have Dr. Kudlu, who will cover long-term outcomes and post-operative challenges.
Am I visible?
Yes,
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 sir.
you are.
Yeah. After a wonderful talk from Titial sir, I think I need to ask him few doubts and all in the end of the discussion part. So today I'll be talking about long-term outcomes and post-operative challenges. This is my financial disclosure, but not for this particular presentation. So just I think already Manpreet has explained about the SMILE, which is a safe and effective refractive procedure for correction of myopia and myopic astigmatism. Superior refractive stability compared to other refractive procedure, and also better ocular surface stability and biomechanical strength. As sir said that you may have some difficulty in the initial period, then once you become the best, I think you can do the case very easily. So I'll be talking about the long-term outcomes, which is measured in terms of visual acuity and quality of vision. So visual acuity is very important because it's concerned with the patient satisfaction. So according to the couple of studies here shown down here, visual acuity, especially it is improved optical quality both in smaller and larger people condition, because already as Rupal said that optical zone is always larger than in optical zone in LASIK cases. Because of that, normally patient will have a better night vision quality. So coming to the efficacy of SMILE for achieving uncorrected distance visual acuity more than 20/20 at around 6 months, which is ranges between 62 to 90%, and uncorrected distance visual acuity more than 20/40 months varies from 95 to 100%. Of course, in high myopia, almost around 85% at 2 years, and low myopia almost 96 at 1 year. Coming to the safety, number of eyes with unchanged corrected visual acuity after refractive surgery. This is very important. See, 4% of the patient gained more than 2 lines. This is very, very important according to the Kamiya Shimizu. And 27% of the patient gained more than 1 line. And 60% of the patient, whatever they had a preoperative visual acuity, same thing they retained. Probably 8% of the patient lost 1 line because of some difficulty during the procedure. Only 0.5% of the patient lost 2 lines, and 0.5% lost more than 2 lines due to some intraoperative or delayed complication. Coming to the predictability. So here it measure of accuracy of refractive procedure. So predictability of plus or minus of residual error. If you think that in myopias, it is more almost in case of 77 to 100% myopes, it's predictable. Out of myopes, around 78 to 92% in high myopia and 84 to 97% in low myopia. So let me come to the stability. It is depicted as change in the manifest refraction spherical equivalent in postoperative period. So what I feel that the why it is a greater refractive stability, because of couple of factors I believe. One is greater preservation of corneal elasticity, and also there is a reduced inflammation smile in compared to can you mute? Can other speaker mute? Okay, thank you. So, if you think about in high myopic, the regressions are slightly higher compared to the low and moderate myopia. That is around 0.2 to 0.36 diopter. So, coming to the visual recovery time, because it may be delayed due to interface haze, even as sir said that initial learning curve and with excess surgical manipulations. So coming to the visual quality, so let me talk about the optical aberration. Definitely there is increase in the total higher order aberration, coma and spherical aberration, but still it is lesser compared to the LASIK. So if the patient is having a high refractive error, definitely there is going to be higher order aberration. followed by exaggerated wound healing response. So coming to the contrast sensitivity, according to our man Dr. Sri Ganesh, he has done a study. According to this study, shows that contrast sensitivity better in the postoperative period, even at a long-term follow-up. Coming to the corneal clarity, interface haze observed in the early postoperative period become almost insignificant after 1 year of surgery. What might be the reason for this delay in the corneal clarity? There might be some deposition of the debris in the interface because of this inflammatory response, excessive mechanical manipulation, and sometimes if you have a high energy level also, this might be the chances. So coming to the corneal curvature changes. See, as I said in previously, the sagittal curvature changes is better preserved in SMILE. So the corneal asphericity with the steeper center and with the flatter periphery is maintained when you are operating a myopic patient. So because of all these factors, definitely there will be lesser induction of the spherical aberration. Coming to the physiological outcomes, normally in SMILE, the corneal sensation decreases after the surgery but recovers by around 3 to 6 months. Let me talk about the corneal biomechanical strength. In SMILE, there will be decrease in the corneal hysteresis and corneal resistance factor on the ocular response analyzer, which is lesser that compared to the LASIK. So SMILE has an advantage of preserving the strength of anterostroma compared to LASIK. This is the one point I always keep highlighting about the SMILE. So coming to the tear film changes, normally gradually it recovers with 80% of the cases being lubricated by giving the lubricating 6 months after the surgery. So which is minimal impact on the ocular surface. Because of the small incision, there is a lesser damage to the subbasal nerve layer, early stabilization of the T-BUD score, better OSDC score, and better post-op corneal sensitivity. So coming to the post-op challenges, most of the challenges already Professor Tithial said. So coming to the interface haze, the incidence is between 5.4 to 54%. The main pathophysiology I can quote here is because of the post-operative inflammation. But these are the few predisposing factors, especially high pulse energy, inexperienced surgeon. Sometimes even epithelial growth can cause even retreatment. So sometimes these interface haze, some of us may mistaken for DLK. So the prevention of this, you need to optimize your laser energy. Once you become the best, better to reduce your laser energy. And management, most of the cases, it's resolved spontaneously. Sometimes you may have to increase your topical steroid. So coming to the dry eye, the incidence of dry eye is between 3.2 to 32%. The predisposing factor patient, if is already having a pre-existing dry eye, so if your patient is having dry eye, better to treat the dry eye, you go ahead with the treatment. Or you can, if the patient is having dry eye, still you can, lot of medications available in the market to treat the dry eye. Most of the patients will be happy after the couple of months. So coming to the cap microstriae, this is very important. See, the incidence is 0.4 to 15%. Especially it is more common when you're treating a high refractive error and also in some of in older patient. So as Dr. Rupal said that the prevention is gentle cap massage after the lenticle extraction is very, very important. So SMILE cap folds commonly present in a concentric circle pattern. When you compare in LASIK, it usually in a linear pattern. So normally in OCT, if you see micro distortions in 88% of the case after SMILE, but it is clinically insignificant. Normally these micro distortions reduced at 1 week, even remain stable thereafter. So once again, for this one, once again, gentle cap massage is very important. You have to use the topical steroid. Coming to the epithelial ingrowth, once again, the incidence of epithelial ingrowth in SMILE is between 0.5 to 0.66%. The predisposing factor, patients with Bowman membrane disease, epithelial defect, even of course with the older patient, if the patient is having a diabetes, and when you're doing the enhancement procedure. So the prevention always, I feel, avoid excess intraoperative manipulation. And outcome, normally mild case have a good visual recovery. In the severe cases, normally patient may have gone for irregular astigmatism with a loss of best corrected visual acuity. So management, if it is in the periphery, observe for the progression, let us wait. If it is progression, intervention is necessary. In such cases, I think you may have to convert into flap, scrape this epithelium. See, in this case, sometimes what happens whenever there is any epithelial ingrowth, few of my friends, even I tried in one cases, you can even try with the NDR laser that clears the epithelial ingrowth. Otherwise, as I said, that you convert into a flap, then go underneath. If the epithelial ingrowth is more, then you have to convert into a flap. If it is in only bothering in the center, still you can open up the incision, go with the small dissector, try to scratch, give the wash. Most of the time it corrects. Otherwise, you can try with the NDR laser capsulotomy. So coming to the undercorrection, of course, especially it can happen when you're treating a high myopia, more than 6 diopters, astigmatism when you're treating around more than 3.5 to 4 diopters. Sometimes, of course, it can even happen with the inexperienced surgeon, even when you're treating a patient 35 years. So the always, as Manpreet said, that careful patient selection is very important. You can try the enhancement procedure with the PRK with MMC. Of course, secondary LASIK also you can do. You have got a circle pattern to for if you are having a residual power, and now they are even trying with the subcap lenticle extraction. Of course, outcome is always satisfactory. Patient will have a good vision. So coming to the irregular topography, the incidence is almost around 0.5 to 1%. The predisposing factor for irregular topography is mainly increased intraoperative manipulation, opaque bubble layer, low spot energy with clear spots, once again with the inexperienced surgeon, and retained lenticule. So always, once again, I keep repeatedly avoid rough dissection and forceful lenticle extraction. So management, you can observe, or you can, if the still patient is having a complaint, then you can go ahead with the topo-guided PRK. So coming to the optical aberration, the incidence is around 0.2 to 0.4%. The predisposing factors are excessive intraoperative manipulation, retained lenticule, if decentered treatment, and epithelial ingrowth. So once again, avoid rough dissection and forceful dissection. So management, once again here, observation. If it is not corrected, then you can think about topo-guided PRK. Coming to the decentered treatment, the incidence is almost 90% within the 0.3 mm of visual axis. But what are the predisposing factor? Large angle copper, very important. Whatever, sometimes you try to dock, you cannot dock in the center. Of course, it can happen with the inexperienced surgeon. So very important, careful centration is very, very important during the docking, during the application of the suction. So once again here, observation, observe, management, observe, otherwise you can go ahead with the topo-guided PRK. Coming to the ectasia, I think reported in 2 cases so far. What are the causes? I think causes are, one is patient might be having because of the low residual bed thickness, high refractory error, even patient sometimes keratoconus might have missed. So once again, as Manpreet said, that careful selection of the patient is very, very important. If they're having, then you can go ahead with the CXL with the smile. If still, then you can think about any of the intracorneal stromal rings with CXL. So coming to my last slide, diffuse lamellar keratitis. The incidence is almost 1.6%. The predisposing factor, once again, interface debris, thin lenticule, larger lenticular diameter, surgeon inexperience, and high pulse energy. So these are the grading. These are the grading of diffuse lamellar keratitis. Grade 1 normally in test topical steroid do well, localized, and grade 2 is diffuse collection of the cells. Grade 3 cells comes, and grade 4 is stromal melting. Only in the grade 1, 2 with the intense topical steroids, the patient do really well. Only with the grade 4, I think, along with the topical oral steroid, and also you may have to give the wash with the interface wash with the BSS. So prevention, once again, thorough irrigation interface. If it has excessive manipulation, as Dr. Rupal said, optimal laser energy and smooth tissue handling, always, once again, outcome will be very good after the surgery. So coming to the infective keratitis, the incidence is around 0.3%. of course, might be mainly due to the contaminated surgical instrument and the environmental factor, and also periocular flora. So always you have to be very much careful while giving the wash before the smile procedure. So management, once again, irrigate the stromal pocket very well, topical concentrated antibiotic, and if nothing happens, then there are a lot of options to correct it. So in conclusion, SMILE is being preferred over the conventional flap-based procedure for the treatment of myopia and myopic astigmatism, owing to its precision, good mechanical stability, and better ocular surface. Greater technical skill is required and has a steeper learning curve compared to the other ablative procedure. Detailed knowledge of various complications, preventive measures, and management is necessary, which is results in the better outcome. Thank you for the opportunity, Manpreet. I thank Titial sir for always including me in instruction course. Thank you, sir.
Thank you, Dr. Kudlu. It was a wonderful presentation. I had one question. What are your results with higher astigmatism, 3 diopter or more? How do they fare in comparison to the lower moderate myopias and lower astigmatism?
So 3 diopters more, actually, before what we have to do, if the patient is having a only pure cylinder, what we used to do, they used to tell us that we used to increase bit, if the patient is having 3.5 diopters. I normally enter in the machine around 3.575 diopter, because chances of regression will be slightly with the astigmatism patient. But patient nowadays with up to 2 diopters of astigmatism, before what you have to do, we have to add minus 0.25 sphere along with the power. When you are entering in the machine, minus 0.25 sphere, along with I increase 0.25 cylinder for the correction of the treatment. But now I think nomogram already changed. I think you are aware of that. You can transpose the cylinder when you're treating. If you're the patient, suppose having a only minus, if you want to treat only -2 cylinder, you can transpose it and you can do it. So higher cylinder, I still remember when I was almost around 7 years before, I wanted to treat a patient with both the -5 cylinder. I was not aware of that. The machine will not take a 5 cylinder. Then I have to call to Germany. They told me that you enter 4.99. But that was the case. I think I had such a difficult manipulation, and I took almost a 45 minutes, and patient took almost 1.5 to 2 years for the recovery. So in the end, there was some amount of regression was there, especially when I was treating that 5 diopter. So now, because of the overall parameters they changed, the regression is not that much. So more than 3.5 cylinder, if you want to treat, add 0.25 more for the refractory error.
Thank you, sir. Dr. Rupal, ma'am, are you there?
I'm there.
Ma'am, do you use any nomograms? Because you have, I think, one of the largest experiences in terms of years.
So I don't adjust any nomograms, but I refract myself, and I think the refraction, the way I do it, for me, I don't need a nomogram adjustment.
Okay.
So
even for higher cylinders and everything?
For higher cylinders also.
Actually, Manpreet, for higher cylinder, I tried actually for at least 5 patients. One, taking the patient in front of the slit lamp, I marked the patient. Then I rotated, like very minimum rotation while just before docking. Then other eye, I did not do any of the marking. I gone ahead with the, because why I am insisting here, because Dr. Ganesh, he always marked the cornea, especially for patient with astigmatism. But according to me, there is no change whether you mark or not. I think Professor Titial has to give us the opinion.
Yes, I also wanted to know whether people mark their corneas. I normally do.
No, we also don't mark the cornea. And to be very frank, I have not gone very high cylinder patients. The cutoff is around 2.5 still for all my SMILE patients. And yes, there was always a consideration to look in for some sort of a nomogram to, if needed. But I believe every machine, every environment is little different. We should not be taking others' nomogram directly. So you have to assess your own cases, your own results, then apply to your machine. So we are in the process of looking onto our patients, at least who have completed more than 1 year. and then we'll decide what is to be done. Till date, we have not had a serious problem. There are here and there some patients are there who may be little undercorrected, or some unhappy patients are there, but reasons may be manifolds. It may not be truly your refractive correction as such. So we are awaiting our results to see what is the outcome after 1 year. Then we'll plan if some change is required.
I totally agree with Dr. Tityal. I think everybody has to build their own nomograms because it depends on how you refract, how you do your environment, your energy parameters. There's so many factors, your wound healing response of the patient. There's so many factors which are playing a role here. So nomogram adjustment has to be done. It's like your A constant, meaning
yes,
you have to derive your own, your induced astigmatism in a cataract patient and stuff like that. Also, I prefer to do high myopia with high cylinders as SMILE and not any other procedures, because I've found that the results are much more stable than anything else that I have done so far. So if I have to treat, say, a -6 with -4 cylinder, and if my cornea is permitting me, I would want to do SMILE if I'm going on the cornea.
As Dr. Rupal said that, I think the machine, what they provide to each hospital, whatever they manufacture actually, each machine they manufacture in Germany, the one they are going to supply to the one hospital might slightly be different from the other machine because of, I think, probably so many other factors. That's what I believe, madam.
Okay, we have Ritika. What's your parameters? Have you adjusted your nomograms?
Sir, we do overcorrect a little bit for high myopia because I have seen that there is a little bit of hyperopia the young patient does tolerate, and after 1 year, most of them were turning out to be myopic. So I started overcorrecting my cases. Dr. Mahipal still did not, but I think then our patients did not manifest as any problem. They were still 6/6 partial, but so I think most people at Center for Sight have now hopped on, especially for higher myopias, to overcorrect to the tune of 5 to 10%. That nomogram also varies between surgeons.
Okay.
I think we'll move on to the last talk by Dr. Ritika. Good morning and welcome, ma'am. Talk is on retreatment, indications, management, and techniques.
Good morning. I'd just like to thank a lot of people here. I think Manpreet for putting it together, Dr. Rupal for giving us SMILE, Dr. Tityal for letting us watch him and spending a lifetime emulating the way he operates. And I think Dr. Krishna for being one of the warmest ophthalmologists and training so many of us in SMILE. So I'd be starting with a topic that actually has been used to criticize SMILE quite a bit, but I think it's not genuine criticism. Are my slides visible? I think I have, yeah.
They're visible.
So SMILE basically is a flapless intrastromal procedure and did not really lend itself to ReSMILE, and that became a pitch point to criticize the procedure. But the truth is that the results of SMILE, as Dr. Kudlu has pointed out, are rather stable and stable for 10 years and more. And the enhancement required is in less than 1 to 4% cases. With us being able to hit the target better with nomogram adjustment, cyclotorsion adjustment, and even doing SMILE extra for patients who we fear will have a lot of regression or risk of ectasia, we now rarely come across patients who need a significant amount of enhancement. That said, there is still the possibility of regression. There are various mechanisms that are at play. One is the epithelial remodeling. Do note that the epithelium tends to thicken post-myopic correction. This is important because when you're retreating, you should know that you're maybe dealing with a thicker epithelium. And also the epithelium remodeling lasts for a few months, at least 3 months. And therefore, you should not retreat before that time. There are changes that happen in the stroma as well. The activated fibroblasts may lay down more extracellular matrix. There are biomechanical changes, and these also may continue for a few months. And you need to map these changes out and really assess the point at which the refractive error has become stable in the form of topography and refraction and epithelial map. This, of course, is not a routine stromal change. This is an case of interface fluid, which can happen due to steroid response, IOP. And in this case, which was reported by us out of our center at Hyderabad, there was a large a tear in the cap, and that allowed possibly tears to migrate into the interface. But basically, these patients may present as an artificially low IOP on applanation, but when you see them on OCT, there's an interface fluid. You see that this patient came after weeks with shifting refractive error and shifting topography. This is not a patient you will enhance. This is a patient you will treat with hyperosmotic agents or IOP lowering agents, and this is likely to resolve. Of course, you also have to distinguish ectasia in patients who do develop refractive error post-SMILE. This is a case report we've published. Though the risk is very low, it is still, unfortunately, a real risk. So all in all, our post-regression after stable refractive results of the residual refractive error and stable scans at least 3 to 6 months later after the procedure, and stability lasting with documented stability across months, we decide to retreat these patients. The retreatment requires you to do a workup, including epithelial mapping, preferably an OCT, of course, a good refraction, and topographic scans. Why is it important to do OCTs immediately after surgery or for a few months? Is that you can see that the planes are much better visible on day 1 and even at month 1. And at 1 year, you may not be able to get the planes as accurately visible. Now, why do we need to know how deep the plane is because when we retreat, we can either retreat on the surface or create an interface. Do note that with SMILE, we already have an interface that the cap has created. So depending on what our plan is, we either retreat from the surface, create additional interfaces by creating thicker or thinner flaps for LASIK, or access the same interface, which is what we most commonly do, by doing the circle scan, which is a cap to flap procedure. And of course, I think we all remain waiting for the ReSMILE, which is work in progress. For surface ablation, though it works very well and doesn't biomechanically weaken the cornea or have the downside of creating a flap, the two things that you must keep in mind is that you are going to remove the epithelium, which is like an overgrown epithelium in most cases. And this remodeling will again take place, giving a longer visual recovery. Also, patients post-SMILE may have increased myofibroblast activities, and you must use MMC in all cases. Though Dr. Dan Reinstein says he does not use MMC, I, for one, would be a strong proponent for using MMC in retreatment cases. Thin flap LASIK basically says that you have an interface of the cap and you can create a thin flap above the cap. This is usually done by surgeons who create thicker caps. We at our end create caps which are about 110 to 120. So we don't have the space to create a thin flap above this. But there are surgeons like Dr. Dan who believe that creating a thicker cap allows you to preserve more of the anterior stroma. So the considerations when you're creating another interface is that you don't want vertical gas breakthrough that will create cryptic buttonholes. So your new interface has to be away not only from the epithelium, but also from the cap interface. The standard deviation of a cut for SMILE is about 4 to 4.4 microns. So you give a safety margin of 4 standard deviations. So you need to be about 18 microns away from the epithelium and 18 microns away from the interface. Having the variation added up on both sides, thin flap LASIK is a possibility when the cap is as deep as 135. Do note that you have to modify your technique for lifting the flap because there are side cut incisions. I, of course, don't have experience with this because, like I said, our caps are not as thick. And you basically tent up the flap and use a blunt instrument to avoid entering the SMILE interface or opening up the side cut incisions. This is what we normally do. We access the same interface that has been created to fashion the cap and create a circle scan to make it into a LASIK interface. Do note that when you're creating a circle scan, this retreatment is safer than relifting a LASIK flap because you have a fresh cut and you don't have risks of epithelial ingrowth. or other complications of a flap relift. Now, when the team at Zeiss was developing this, they actually came up with 3 patterns. The cap does not extend as much as the flap would. So you need to increase the width or the horizontal extent of the cap. For that, an annular extension is made, which then communicates to the surface with a side cut. But it also has to communicate with the cap because the depth may not be as spot on. So the pattern that they made for the annular extension and the side cut met the cap either with a junction up cut, a junction down cut, or an up and down junction cut. And they found that this cut, the 4th cut, is what is the easiest to dissect. And therefore, this is the one which is widely used. There is, of course, another option called the side cut only, that in case you made a very large cap, which allows you to have only a side cut to access the cap and gives you enough optical zone to treat, you can do simply a side cut option. I would also like to highlight this option because this can be used in cases where you've had suction loss. So a side cut option converts the cap into a flap. You have to make it smaller than the cap by about 0.2 to 0.3 microns and go deeper than the cap to compensate for an epithelium that may be thicker or a standard deviation of the depth not being at the exact. This is what the thing looks like at the machine. You choose the circle mode and the first mode is the side cut. You see here the diameter has to be less than the cap. The depth has to be more than the cap. And then you can simply create the side cut. This is what we use, the circle scan. This is the first cut that comes in. This is the junction cut, which allows you to communicate with the cap. The annular cut, which expands the cap so that now you have a larger flap, and the side cut that then comes in the end. This is what the screen will look like. The outer diameter here, of course, since we're using 8.8, we'll use the medium size cone. This is what the flap diameter will be like. This is where the hinge will be placed. This is the depth of the flap, which you keep same as the cap that you've made. This is the inner diameter of the junction cut, which has to be less than the cap diameter. This is the junction cut, which normally straddles the cap depth by 20 microns. So if I have a 120 micron cap, the lamellar cut is at 120, but the junction cut will be up and down by 20 microns. You see here, though you can use any pattern, this is the best pattern, making it easiest to dissect. So this is the patient interface being latched on. You see here the junction cut coming in, the annular cut coming in, and then finally the side cut coming in. So once this is done, though there are some cases where you may have increased resistance, possibly due to the change in the fibroblast, this lifts up rather easily. You should first go into the annular area and then go into the central area. And though you see sometimes a small step, this has no visual impact and the flap really fits back very well as a lock and key method. The results of circle scan are rather gratifying. Like I said, the treatment is restricted to very few proportions of patients who do require enhancement, and more than 90% of them do come to the eventual visual outcome of around 0.5 diopters. And the, of course, downside is to create a flap. This is what the panacea would be to do a re-smile, and though there are people who have shared videos of that, it remains not commercial yet, and it is a little more tedious and still not available for commercial use. So all in all, SMILE offers stable refractive outcomes with options for enhancement. And I think as SMILE surgeons, we are very happy with the possibilities it gives to the patient and the surgeon. Since we have time, I'll just like to take an opportunity for a pop quiz. This is we discussed this yesterday. Dr. Rupal ma'am possibly has the answer. This is a patient being taken up for SMILE. And you see as the pattern comes in, there is a big dark spot that has happened. And when there's such a big dark spot in the posterior pass, do note that posterior pass is very important because that's going to define the refractive result of this patient. So we abort the procedure and basically counsel the patient that, you know, you should ideally we will be aborting the procedure, possibly doing a PRK. Now, why did this dark spot happen is the question we had in mind. And this spot actually happened to us in 3 cases and not 1. So the question is why it happened.
I'm not going to spill the beans.
Yes. so I think I'll just want to highlight this, that this is what shows why it happened. This happened to us on the intralays also. Since the patients are wearing a mask, the breath escapes superiorly, and there is a condensation on the patient interface that is happening, which is causing an obstruction to the femtolaser pass. So this is a COVID phenomena, and now an advisory has been issued by even J&J for the intralays. So when either you make the patient unmask and lift the drape so that the breath goes down, or you tape the mask. So basically, just like to end by saying that we all live in uncertain times. Though SMILE gives us certain results, we still have new uncertainties that COVID has brought us, and hoping that this too shall pass and we meet in person soon. Thank you for your attention.
Amen.
Thank you, ma'am. This
No,
was. So please go ahead.
No, beautifully, expressed the entire gamut of a retreatment possible in a SMILE patient. As he rightly said, thankfully, you don't have too many cases where we have to think of retreatment. And that's why we are also not in a, you can say, right mode of planning these cases, how to go about this. Number of cases so less, you can't really design a protocol for these patients also. But I'm sure as time passes, we'll have a definitive guidelines to manage these patients post-SMILE retreatment. And at this stage, if you consider me also, I'm very hesitant to think what should I be doing for a patient if they require a retreatment. I think there have been one or two cases where we had made a flap, that to aborted cases. And subsequently, I've yet to do a retreatment for any SMILE patient. So if such instance comes, then I have to ring up so many my friends who have done these, matters, the circle pattern. I've yet to do a circle pattern also. So it's lucky that we don't have so many patients. The people should go with a positive mindset that SMILE is very, very safe procedure, safer than any other procedure on the cornea. And as Ritika talked about the COVID phenomenon, I think it's correct. The mask is creating so many things, not only for surgery, for a routine people also. It's creating, as Rohit Sethi talks about, different type of dry eye condition where you have a hypoosmolarity in the cornea rather than a hyperosmolarity. So that is one thing. And we are also very soon going to come out with the results of mask and its relation to the ocular surface. But in RP Center, we do a proper, you can say a drape, which covers the entire eye from the face regularly. And that prevents the anything coming towards the cornea side. But if your drape is not correct, then you are, Ritika, absolutely right. This breath of a patient under stress will be different, and that will have many more things to create. I have seen some patient where you have both eyes behave similarly in terms of black spots coming up in the same area. And if we look into their lipid profile of a tear in a pre-op condition, that might give you some clue, like how unstable the tear will be, or what is the lipid profile. Because if your lipid profile is not good, you may have more chances of getting a dry spots in these cases, because whatever film is there is not going to be stable for a longer period. And it comes in the same area, in almost both eyes. So that may be some sort of a TM film phenomena with the lipid layer may not be as good as normal cases. But this mask phenomena is something different.
Thank you, sir. Thank you, Dr. Rupal, Dr. Kudlu, Dr. Ritika. This would not have been possible without you, and for a wonderful IC. And though I was the chief instructor, I was learning from all of you. And we have run out of time. Thank you so much. There's a keynote address that has to be played after this, recorded. So I think we'll end our session. And
whatever said is done, you may be a chief instructor, and looking at all the pictures, you are looking most comfortably, placed. We are at a serious stress.
Thank you, Dr. Mike.
Thank you.
Thank you, ma'am.
Thank you,
Thank you all.
Thank you, sir.
Thank you, sir.
Thank you, doctors. Thank you.
मैम प्ले करना है कीनोट एड्रेस?
yes, आप प्ले कर दीजिए.
Okay, I have to join other session. I'll go.
Yes, sir. Yes, sir.
Good evening. This is Dr. Gyan Prakash at the National Eye Institute, National Institutes of Health in the USA. I wish to thank the leadership of AIOS and the program committee, everyone, for inviting me. Thank you so much. Really appreciate being with you virtually and sharing some of my thoughts and sharing some information from the National Institutes of Health, the National Eye Institute. The topic that I've been given to talk about is the global initiatives and the long-standing 15-year relationship of Indo-US collaboration in vision research. Let me start by saying that that I have no financial obligations to declare. Thanks again to the organizers and the leadership of AIOS, and the opinions expressed here in this presentations are my own and not of the United States government. The government does not bear any direct or implied responsibility for the information. So many of you have seen, this is the National Institutes of Health campus just outside Washington, DC. As several of you know, that we are an agency of US government, Department of Health and Human Services, which is like your Ministry of Health in India. And we conduct and support medical research to uncover new knowledge to improve the health of all Americans. And this is something I like to highlight here, is that our mission also includes the working on the human conditions throughout the world. And there are 27 institutes and centers within the NIH. National Eye Institute is one of the centers, one of the institutes. As you can see here, this is National Eye Institute and other institutes and centers. Our mission is to conduct and support research, training, health information dissemination, and everything that relates to the visual function research, preservation of sight, and things like that. So essentially, everything that relates to eye diseases, prevention of blindness comes under our purview. This is Dr. Michael Chang, who is the new director, just recently joined as the new director of National Eye Institute. In terms of our specific mission, as you know, we are working on advanced knowledge of the visual systems. In order to prevent and treat eye diseases.
Can we have the next session started?
Improving the quality of life for people of all ages. And just this year, our budget is approximately $835 million just for this year. As you can imagine, that this amount of money that gets spent just on eye diseases. And our our view is that global science is very interconnected. We are very actively involved in global research. We seek scientific opportunities, identify shared priorities, support unique international opportunities. And we also, big part of our mission is to support US domestic grantees to expand international collaborations, forming partnerships among scientists, governments, companies, NGOs, and so on, to really leverage NIH funds to ask important questions that relate to biology of life.
Dr. Manpreet, we are running short of time.
Always that anyone from any country around the world can apply.
Yes, sir. I think the next session can be started.
Science 101 grants, which is, here's the link for that.
Purnima, requesting you to start our next session.
Grants and
good morning, everyone.
PIs, principal investigators, scientists, clinicians, all over the world. If you've got good ideas, we are looking to work with you. In terms of overall, just a big picture view.
Everything we can forward this and we can start.
We have research programs, training programs, and other special programs. So that grants goes out to the US. Research programs began working with California and San Diego, Shroff in Delhi, working with MIT in Boston, Project Prakash in California and San Diego.
I would request Dr.
In Delhi,
Rohit or Prakash to please take the lead.
Boston, Project Prakash, of course, that many of you have heard. So there were just a very significant, good accomplishments of California and San Diego.
Ramesh, can you please stop the video?
In Delhi, working with